Good afternoon, everyone, and thank you for joining us for today's webinar. Today, we will take a look at regulated competition as a driver for access, quality, and financial sustainability in health systems, and what we can learn based on the experience of the Netherlands. It has been a little bit more than 15 years since the Netherlands introduced a sweeping reform, which implemented a mandatory health insurance system with free choice of insurer for consumers. And so based on this new reform, private insurers have to compete for enrollees, and providers have to compete for contracts with insurers. And the role of the state is limited to the regulatory system and surveillance system of these relationships. So today's webinar is inspired by a book published by the European Observatory on Health Systems and Policies and written by Jeurissen and Hans Marse, which aims to evaluate how this reform in the Dutch healthcare system, and in particular how regulated competition, has affected the financing, purchasing and provision of healthcare in the Netherlands, and also what we can learn for policymakers in other settings based on this experience. We have an excellent group of speakers to discuss this topic. First of all, we have Jeurissen, who is the main author of the book and is a professor at Radboudumc University Medical Center in Nijmegen in the Netherlands. And he will give us a keynote presentation highlighting the main findings of the study, and in particular what this means for decision makers in other settings who might be considering similar moves. We will then turn to Switzerland, a country which has several insurers, mandatory insurance and regulated competition, and has had it for even longer than the Netherlands. And we will hear from Carlo Pietro at the University of Applied Sciences and Arts of Southern Switzerland about the Swiss experience and his views, in particular on regulated competition and the effects of the model there. We then will turn to Luigi Siciliani at the University of York in England, and his views on regulated competition, and in particular how provider competition has shaped the quality of care and access to care in the NHS. So we have all our distinguished speakers, and we're really looking forward to discussing this issue, which is very interesting and has been discussed quite a bit in the International Health System platform. But we also want to hear from you, and we ask you to share your experience and your questions with us and with our speakers, and to use the chat function to do so. And my colleague, Erica Richardson, will be keeping an eye on the chat room to make sure that she captures your insights and reflects them back to the panelists. And she will also kick us off now, before we go to Patrick, with a poll question for you, for the audience, so that we can get a little bit of action starting the webinar on your thoughts on regulated competition. Erica, over to you.
Just a couple of quick questions to see where we are. So first of all, is competition in the health sector a good idea? Just a single choice yes/no question. But then to go a little bit deeper, does competition in health system achieve any of the following? And this is just your opinion, but does it contain costs? Does it improve quality? Does it improve transparency? Does it improve access for all? Does it improve patient choice? So just a few ideas to see where we are with the audience. And I'll come back to give you the results after Patrick's presentation. Thank you very much.
Thank you very much, Erica, and for keeping us in suspense about what our participants think. So we are here from Patrick first, and then we will hear what all of you think. So Patrick, I will hand the floor over to you for the main findings of your excellent study. And you have about 15 minutes, and then we go to our spotlight speakers. Thank you very much. The floor is yours.
Yes, thank you, Dimitra, and good afternoon, everybody. It's nice to be here, and a big thank you to the Observatory and Joseph and his staff to make this this book possible. And I also present on behalf of my co-author, Professor Hans Marse. So what I'm going to do is not explaining the whole book to you. I think it's you can download it, and if you're interested, you can read much more. But I will try to give you a couple of main lessons. So to start it off is basically this slide. So we see here, I guess, that the Netherlands has, according to Caroline Tououi, made a blueprint reform over at least 20 years, starting in, say, 1992 until 2012, with 2006 as, say, the main the main event of an entire new law. So I think these reforms are as close to a kind of blueprint case of managed competition as probably exists around on the globe. So I'm not going into all the different institutions and conditions and characteristics, but one thing is very important, and that's that the purchasing market is very liberal, with lots of space for the different actors. So there's free pricing, there's more or less free contracting. There's no certificate of need, or hardly any certificate of need. So there's very liberal purchasing market. Of course, we also have history and part dependency and things that were and that still are. And of course, we also have ongoing disputes that I say not so much part of the blueprint. So there's a lot of debate on the issue of for-profit ownership. But for example, so many people will think, especially from an international perspective, that this for-profit ownership would be more or less allowed. It's largely not. There have been discussions on the fact if we need a global budget, especially in the early years. Many people doubted that was needed, but still it's still there. And now there are also discussions about actually should we have freedom of physician choice, or should insurers even have more incentives to steer patients to their networks. But still, it's a blueprint. So what I'll do is I present briefly 5 lessons, 5 takeaways, which I feel are rather typical and not always that known in the broader health system community. So I think the first one, and that's is that starting in 2012, what we witnessed was a very slow growth in healthcare expenses. You see on the left, you see real per capita growth in the Netherlands, and you see that how it declined a lot, but you also see that it's less, substantial less than surrounding countries, including Switzerland and the UK, which we hear later in this session. What I personally think is even more remarkable is on the right hand side of this slide, is that we went from a history of overspending in billions of euros towards underspending starting in 2012. It basically means that every year until now, not all money that the government more or less allowed to the healthcare sector has been spent. So I think that's one lesson, and that lesson even becomes more clear if we also realize that in the same period, so the last 15 years or so, the balance sheets of both insurance companies and healthcare providers has strengthened a lot. So in 26, it's hardly seenable, but sickness funds needed to have 8% solvency. In 2017, many reforms on risks, etc., it's around 17%, and in theory, or not in theory, but typically an insurance company holds even 50% more than the set rate on the Solvency II. You see it here. It basically means that the average solvency of insurance company now is 30%. If you look at the hospitals and you look at the red line here, you also see a steep increase in solvency levels. So remember that all these strengthening of the balance sheet has basically been done over a period of years when there was extremely low growth in cost. So I think that even more states about the strengthening or the financial strength basically of the whole reform. But also, and you see that here also on the right hand side, you see that we have more rich hospitals. So those are the top gray line. Those are the ones with the strength, the balance sheets that are the most strengthened. Typically university clinics and larger tertiary care hospitals, but we also have much weaker hospitals, and the difference between them has increased. And that kind of brings me to a third lesson that we have witnessed over the past 10 to 15 years, increasing diversity and segmentalization on the different markets. And I show you here basically what happened on the insurance markets for the consumers, where we saw substantial adverse selection. We saw that people were less willing to take up supplementary insurance or complementary policies. We see that people chose much more for narrow network policies, who are much more cheaper, well, much more around 100 euros cheaper annually, but also allow you only to a much smaller network. And we also witnessed that more and more people chose for voluntary deductible. So the starting year here was more or less 2012. And that's not by coincidence, because starting in 2012, we actually saw that the insurance companies in that year became much more, faced much more risk. It also tells us these choices for cheaper policies, that risk adjustment, sophisticated risk adjustment in the Netherlands, as we proudly used to say, maybe isn't that capable of stopping this trend of adverse selection as it is. So diversity is another, and we see here that the spread between the lowest and the most expensive plans on the market has increased substantially in the last 4 or 5 years or so. Then the fourth lesson is that the system, especially for providers, has substantial administrative expenses or indirect costs in hospitals, summing up to around 40 to 50%. And you see it here on the right-hand slide. You see that the typical overhead expenses in Dutch hospitals are second to the United States, with around 20%. And if you realize that the non-patient time of physicians, nurses, etc., is not included in here, we will go in a direction of 40. On top of that, we still have, of course, expenses for the insurance companies, which actually are very low in the Netherlands and have been declining administrative expenses. So no claim ratios are stiff above 95%. But overall, the picture is that this is substantial. And if you see, for example, on the left-hand slide, you see a US Commonwealth Fund survey. And you see here that Dutch GPs tell that they are most overburdened with administrative work, and it still is also at the moment. A time of GPs is a substantial problem. So that brings me to the final lesson, and the final lesson is about what's actually the core of the whole reform: active purchasing. And what we see here is that we do not find a lot of evidence that active purchasing changes the way insurance companies steer their resources. So we have designed here with a colleague, Niek Stadhouders, a so-called market activity index, which measures changes in turnover between different types of providers. And you see here that hospitals, which of course are steered by regulated competition, that changes on the hospital market are in the bottom half of this slide, don't look at the peak. That's a statistical break of trend in 2015. But the dark blue is the hospitals, and the hospitals are changing market share around as much as nursing homes or elderly care or disability care. You can look at a little bit better on the right hand slide. Why we would expect that, because elderly care and disability care are not part of regulated competition, but are basically a single purchase under a single purchase program. We would expect actually that hospital care would be changing more, and it doesn't. If you look at certain other characteristics, so for example, does the level of having a contract by an insurance company, does the quality of care measured in indicators, does that matter if in creating additional market share, or does scale matter? We all find that it's all non-significant. So it basically means that although cost containment has been very successful, active purchasing has across the board really helped for that, but not so much steered resources in all different kinds of directions and providers. So that brings me basically to the last slide, and some conclusions, because we have of course much more, but basically to sum up, a blueprint reform, I think we had, without big, at least adverse effects regarding quality of access, we couldn't really find. Of course, we did find positive effects if you are on that line on cost containment. We also witnessed that some political disputes, like on for-profit ownership, like on budgets, like on freedom of choice for physicians, they typically continue for the last decade or so and still have not been solved. Very low growth of expenses, at least for the last 10 years. Of course, it doesn't mean that that also will be the phase of the future. Strengthening of private balance sheets of the insurers and also of most providers. But we also saw that our sophisticated risk adjustment did not really stop a trend of adverse selection and diversity and increasing segmentation among both enrollees, but also among providers, with some getting in trouble, others not. Substantial level of administrative expenses or indirect cost. And finally, that active purchasing it does not so much seem to change the direction of how resources flow. So I think I'm quite on time, I hope. Thank you for your attention, and over to you, Dimitra.
Thank you very much, Patrick. Absolutely on time. So thank you very much for that and for the very insightful presentation. Let me say from my perspective, for those of our participants who haven't read your book yet, all of the key conclusions or insights that Patrick presented are there, but there's also very interesting scholarship on reforms per se and what to think about in the initial chapters and through the book. So I would definitely recommend going into that as well. Patrick, when we come to the discussion, I will come back to you to ask about if the COVID-19 experience has changed a little bit the discussions, or how this trend to more budget plans, how it reflects on the necessity or the, let's say, how consumers make choices, because one of the main tenets of the reforms were also freedom of choice. But if they opt for narrow networks for financial reasons, where are we with that exactly? But more on that when we come back. Now it's time to hear the results of the poll from Erica and see if what our participants think chimes with what Patrick has been talking about from the experience on the Netherlands. Erica, over to you.
Thank you very much, Dimitra. If you could put Annelies, if you could put the poll up on the screen. So, yes, most of the people in the audience feel that competition in the health sector is a good idea overall, about 2/3 to 1/3 thinking that it isn't. And where competition might achieve results in the system. The focus is very much on improving quality and containing costs. Access for all, much lower down. Similar for improving transparency. And just at the bottom, the big winner is patient choice. So very interesting results. Very interesting indeed. Thank you very much.
Indeed, I just want to thank you, Erica. I want to reflect. We didn't specify which type of competition or who is competing in this question, right? And it was interesting, I think, on Patrick's last slide, the level of trust among people surveyed in the Netherlands who put trust in the providers, but not trust in the insurers necessarily, or that's the way I read it quickly. Patrick, so maybe we come back to that in the discussion. Thank you very much, Erica. Thank you to all of you for participating in the poll. Before we go into a broader discussion, what we want to do is take some spotlight views from different settings with regulated competition. And Carlo, we come first to you and to Switzerland. And there you also have mandatory health insurance with regulated competitions for insurers. So give us your experience and how it chimes or doesn't chime with what Patrick talked about.
Thank you very much and good afternoon to everybody. Thank you very much for this invitation. Yes, we have the same label, regulated competition. Switzerland started 10 years before Netherlands, but with very different historical roots. As Patrick correctly said, in Netherlands, the state wanted to step back from healthcare sector. In Switzerland, this regulated competition was on the opposite side, a step in by the state, because before it was very much different among cantons and in general with a lot of role for private insurers, but also private providers. So, of course, labels are always the same, but histories are always different. I tried to organize here for you, let's say, some remarks around the three markets: the health insurance market, the healthcare provision market, and the healthcare purchasing market. So, basically, from a Swiss point of view, what I can say is that the health insurance market, it's sticky. It has a sticky competition. We have a lot of signals of this stickiness. We have low annual switch rates, that is also common to Netherlands. We have a lot of insurance funds with a very slow movement towards merging. We have also very different premiums for the standard coverage with I can choose between insurers that have premiums from 1 to 2 or almost from 1 to 1.6, so much higher or much cheaper. On the other side, the healthcare provision market here in Switzerland, it gives really a high freedom of choice to insured people or to patients. Traditionally, people can access directly to the secondary care. And they also can consult everyone in the system paid by the mandatory insurance. Recently, there was a quite rapid evolution, quite rapid diffusion of plans with, I would say, light gatekeeping from GP or by phone. And yeah, the big problem, as in other countries, of this health provision market and this freedom of choice that consumers can choose, but without information to do the rational choice. If I switch to the last market, the market between insurers and providers, here the big difference with the Netherlands is that in Switzerland, for the ordinary model of health insurance, laws set lot of limitations. Basically, selective contracting is forbidden, and also active purchasing is very, very difficult for insurers. The only option to, let's say, get out of this difficult condition, this very rigid market, is to give the possibility from the insurer side to develop managed care plans. In that case, managed care plans are not so much diffused, but the people can enroll with these plans in order to pay a lower premium, and of course these reduce the choice of providers available to insured people. After 25 years, this is my last remark, from this, however, huge, I would say, blueprint reform, as Patrick correctly said also for Netherlands, what we can say about the three main goals that were set as goals of this reform in 1996. There is a gain in solidarity. Yes, there is a gain in solidarity between the healthy and the sick, but there are a lot of problems in the solidarity between the rich and the poor. Is there a gain in quality? Yes, maybe there is a good quality, or for sure there is a good quality in the healthcare system in Switzerland, but this is not really the impact of the reform or of this regulated competition. I think it's much more the impact of having a lot of services and resources of quite good quality with a lot of freedom to provide services to the people. The very last point was cost control, and in that case, cost control was maybe the biggest failure of this blueprint reform that was established in 1996. This is all for the moment. Thank you very much, and maybe we can go in depth with comments or with questions from the chat.
Definitely. Thank you very much, Carlo. We will definitely come back to both the issues of quality and access when we come back to the discussion, because I think you raised both of those. Very briefly, Luigi, before we come to you, just to point out this issue of the blueprint reform that both Carlo and Patrick referred to. This is also described in Patrick's book and is based on previous scholarship. Let's say this is a fundamental reform that goes at a relatively slow pace, as opposed to a big bang reform, which is a fundamental reform that goes at a fast pace, just for those of us who may not be familiar with the term. Luigi, we come to you to reflect on the English situation, and particularly in the area of provider competition, and what you have seen based on your experience in the past few years. Thank you very much. Over to you.
Thanks, Dimitra. So in England, we have had the competition for quite a long time. So since the internal markets in the 90s, when we had the purchaser-provider split. And we know that competition is like a multidimensional concept. So it really means different things to different people. So here I have singled out like three different dimensions of competition. So I'll go through quickly in the context of the National Health Service in England. So the first one is patient choice, and that also came out in the poll. If you think about competition, that's what many people think that this relates to, is that suddenly patients can choose. So in the context of England, before 2006, patients had quite limited choice, and then after that, they had at least a choice of 4 providers, and then this was in 2008. This was expanded to any qualified provider. So basically, patients can choose any hospital in England. And this was also supported by lots of public reporting. So you can go on the NHS website and you can find mortality rates, waiting times, user rating, food choices. So there is quite a lot that, so patient choice has been supported quite a bit through public reporting. So what does the evidence say about this, for England and perhaps also other countries? Well, we have quite a lot of evidence, and the evidence suggests that quality does matter. So patients exercise choice. So hospitals that have higher quality, they do get more patients, but the effect is relatively small. So how small is small? So if you increase roughly quality by 10%, then you get 1% extra patients. So that's how much choice is exercised. Summarizing quite a lot of evidence in a nutshell. So once you have patient choice, and I'm moving to the second element, then you could use this to stimulate competition across the providers. So in some way, you could think that patient choice is a prerequisite for hospitals to compete with each other. If there isn't any patient choice, why should you make an effort to increase quality when you're not going to attract patients? So that also goes hand in hand with activity-based financing of the DRG payment kind of type, and that was introduced early on in 2003 in England, and so from that point onwards, you had patient choice combined with payment by results or activity-based financing. So that the idea was that hospitals could compete for patients. So you could ask the question of well, what does the evidence say about that? So here again, we have several studies that have looked at England with good statistical strategies. And what they say is that if you look at indicators like a heart attack, then the more competitive areas had reductions in heart attack mortality. But the news are a bit mixed, because that result does not translate to other indicators like stroke mortality, for example, or mortality for coronary bypass, or readmission rates for hip and knee replacements. So that's what we know from England from that period. If you go back in time, so in that sense, maybe here I'm making a connection with the Dutch context. If you go to at the beginning of the internal markets, where the purchasers were negotiating on prices and quality with the providers, there actually the news seemed to be not so good, because some studies have shown that in that form of competition, where the prices are not fixed for the hospitals, then actually that led to an increase in heart attack mortality, but did reduce waiting times, possibly because at that time we didn't have all these quality indicators and public reporting. So that's what we know about the second aspect of competition. So let me move quickly to the private sector. So that's what some people think what they associate with competition is that competition means introducing and allowing private providers and private hospitals to enter the market. Now, within the context of the National Health Services, National Health Service in England, that has happened. So if you go back in time, the private providers didn't treat basically any patients, and then over time they have specialized in some non-emergency elective treatments. So these days they actually treat about like 30% of hip replacement patients. Now, the way you think about private sector in the context of competition really depends. So the way I think about the private sector is that this is more related to the organization of the supply and the healthcare services. So if you look at the Netherlands, they have decided that there is just one type of hospital, which is private non-profit hospitals. Other countries have a much more mixed kind of level of organization. Italy, for example, you have public hospitals, private non-profit, and private for-profit. So there is a whole question. I mean, that leads to a different question, which is which one is the best which one is the best provision? Should you have public or private hospitals, as I think Patrick was hinting? And the only thing I can say about that is that the evidence is actually quite mixed. There isn't the evidence does suggest that private providers are necessarily doing better than public providers or the other way around. One thing that is though pretty clear is that whenever you have a system, when you have public and private providers, the private providers, they do treat the patients with lower case mix, the less complex patients. So then you have to think about what you're going to do about that if you're going to allow a mix of public and private providers. Now, going to my last point, after 30 years of competition, competition has actually dropped from the agenda, from the health policy agenda, and most of the discussion are instead about integrated care. So we have moved from competition to integration. You may wonder what happened to these different elements of competition that I have just outlined before. So if you think about patient choice, I don't think this is going to disappear. I mean, even if you move towards integrated care, there is still quite a lot of emphasis, even more emphasis on patients getting the best care and through coordinated care and with an element of patient choice. So it could be that that element of patient choice might remain. What about the second element, the quality competition? Well, that actually might drop. There is a lot of discussion about moving from activity-based financing to blended systems where you have these much smaller tariffs combined with some capitation payments. On the other hand, if you look at the current strategy about how to deal with the backlog, there is an acknowledgement there that probably you will need activity-based financing to make sure that hospitals have an incentive to increase supply. So maybe even that part might remain. And then if you think about the private sector, again, if you think about that backlog strategy, you have this capacity in the private sector, is quite likely that this is going to be used. And my very last point about integrated care and competition is that, well, if you do move towards designing integrated care packages, for example, primary care providers and GP practices that now take more responsibility, well, those primary care practices, they could still compete for offering these integrated care packages. So in that sense, integrated care is not necessarily incompatible with competition. Thank you very much.
Thank you very much, Luigi. I think this was very rich in information, and I think also quite clearly showed the mixed, let's say, evidence that we have for different things. And very interesting that you brought in this issue of backlogs, clearly linked to the pandemic response earlier in the pandemic. I think we come back to that also in the discussion. I have so many questions for all of you. I'm going to keep my mouth shut for now because we go to Erica, who will tell us what's been going on in the chat. Quite a bit based on the pop-up windows I've been seeing on my screen, and on very important areas as well. So Eric, over to you. Give us a summary of what's going on.
Okay, yes, a very busy chat box, but do please keep your questions and comments coming in. And quite a lot of interest in very specific technical questions on the Dutch health system, but I'm going to try and broaden them out a bit. So, but one which seems to be quite important is when insurers and hospitals increased their solvency, was it because they underspent, or was it because they rationed care? And did that rationing happen at the GP level through gatekeeping and things like this? So what was the impact of these reforms on utilization and access? I think that's the sort of like fundamental question going on there. And what about the role of co-payments in the system? Again, this is more for the Dutch and Swiss examples, but there was a particular question about the 385 annual own care sort of co-payment in the Dutch system. And what role does it have in achieving cost containment and choice of provider? And then another broader question is about whether or not competition in these three settings has developed according to its legal definition and framing, or were there unintended consequences? And what are those unintended consequences? And what should other countries be looking out for? So some really interesting ones to start with, but keep your questions and comments coming. Thank you.
Indeed. Thank you very much, Erica. And I think it would be great if we could have our other panelists on the screen as well for the discussion. Quite a lot to think about. I think let's start with the last one that you brought in, Erica, because I think it was very clear also from Carlo's slides, this idea of how competition evolves based on the regulatory framework around it. And I think the question from our participants, if I understood it correctly, and please jump in again, Erica, if not, is how we can make sure that it has actually achieved its goals based on the let's say the legal or regulatory framework around it. We heard from Carlo that cost containment is not really, let's say, a success in Switzerland. It is in the Netherlands. At the same time, we don't really know about access to care. So Patrick, I come to you first. There is quite a bit in your study about how to frame this right or how to regulate it. What's your insight on this for those of our participants coming perhaps from a slightly less regulated setting than the Netherlands?
So sorry, Dimitri. So you mean my insights on the regulation?
Mm-hmm.
Yeah. So I think basically that, and I didn't discuss it, but that regulation only is not enough. So in the Netherlands, there is a complex hybridity between, on the one hand, all kind of sophisticated regulation, which is, needs to accomplish all kind of goals like access, cost control, etc., etc., etc. But on the other hand, it's also very much about a corporatist governance, where people kind of talk to each other and kind of make that more or less work in practice. So it's maybe a bit of an abstract answer, but
okay, no, I think the stakeholder engagement and exchange part, I think, is quite an interesting link. Carlo, can I come to you and ask, from your perspective, you highlighted already quite the different background out of which this trend emerged in Switzerland and how it's different from the Netherlands. In your view, what is the frame to set around it so that we actually get it to work the way we want it to work?
It's really a difficult question. What can I say? Maybe from the Swiss point of view, I can add this particular story, a history with this federalism and the direct democracy. Usually, the politics and also the political system has a lot of impact on the pathway of reforms. So, if I come back to your remark, Dimitra, about the failure in cost containment. Maybe there are two main reasons. From one side is that Switzerland is rich enough to pay for some inefficiency. And on the other side, there is this direct democracy. And every attempt that the government tried to do for reducing the quantities or reducing the unit prices or other interventions, the people with votes said no. So, for instance, just to give to our audience an example, there was a very debated referendum in 2012 to introduce the managed care as let's say the standard form of health insurance, and the people said no because they didn't want to lose 1 centimeter of freedom of choice of the procedure. And this is not all the population; it's the majority of the population, because at the same time in Switzerland we have a little but increasing number of people that do choose to have managed care as their mandatory health insurance model. So I think that there is not a specific answer. I'm not able to provide it to you.
No, I think that's also very clear that, depending on the outset of where you are, you will need to think about this differently, and different health systems and different populations will probably be more or less willing to go a certain way. I'm assuming, Luigi, perhaps I'm linking a little bit to you now with the purchaser-provider split in the 90s. It's quite a different system when it comes to the financing compared to the other two. But you've also seen this evolution of how patients in England react to the competition concept. And so, from your perspective, how does regulating this actually affect how it works in practice?
Yeah, there are two points there. So I think the first one is that I think regulation or the legal framework is fundamental for the whole thing to work. I'm thinking, for example, in relations to hospital mergers. This was like the CMA, the antitrust authority, they were in charge of allowing these mergers or not. And now this has been taken away from them. That's my understanding. So there are lots of important decisions of who is in charge of allowing hospitals to merge, which is the opposite of competition. By allowing all these mergers, patient choice might suffer, competition might be reduced. So regulators have a very important role there. The second point that I want to make is that I think the problem with the competition topic is that we tend to analyze this in isolation, saying what is the effect of competition or competition against other models? While maybe we need to think how competition supports other policies that are being introduced at the same time. because in the end, the competition is just like a tool, a policy tool that is supposed to help to achieve quality, efficiency, and so on. But it cannot be the only one. And actually, we look at from the evidence that we find mixed effects. So probably by channeling these efforts in the right way, maybe this can be useful. But maybe the next step for this debate about competition is, what are you doing? You cannot check whether competition is useful or not unless you think carefully about all the other policy levers. What are you going to do on quality reporting? What are you going to do, like pay for performance? What are your main other tools to increase quality? And maybe then to try to design the competition elements in a way that support the others. So otherwise, all these different elements, they are evaluated in isolation, and then you end up with a monster that no one understands. I'll stop there.
No, I thank you. This is a really important point about looking at this in conjunction with other things. You mentioned quality, and we also had in our questions, and you also touched upon it, the issue of access. So let's, I think, go first to the quality issue. Luigi, in your setting, there is a lot of information, as you said, in terms of public reporting. There was an entire framework for actually also understanding the quality of different providers. In Carlo's spotlight, we heard there is not a lot of information on quality, but we expect there is high quality. In Patrick's presentation and in the study, we see that the effects perhaps are not as significant in that area as we have cost containment. So what I would like to do is go back to Patrick and think about this question of how can we do more on quality and link it with what we're doing already in terms of competition, freedom of choice. In that sense, can we trust that the people seeking healthcare are making the right choices? Can we trust that we are working on quality in this area? And then I think I'll take the same sequence, and we go to Carlo for a moment, and then we go to Luigi. Patrick, first over to you.
So on quality, I'm with Luigi on the point that in the Netherlands, 70% of hospital prices were totally free, starting from 2012 onwards. And that kind of led to the fact that insurance companies were very much focused on price.
Yeah.
The price, and price was not fixed. So so I think that's one reason why quality didn't at the beginning take got a big role in contracting. Now I think that has increased a bit over the years, but still, if you look at the number of quality indicators that are around in the Netherlands, something like 2,000. Still, I mean, they're usually underused in contracting, and that's basically what the evidence shows. Now, of course, that's only one part of quality, right? So is it contractable? And if it is contractable, will you contract it? The other thing, of course, is do we still have a lot of new innovations, new drugs, etc., 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 etc. And I think those things rather have been on par the least with other countries. And then, of course, the third thing is that if you do have non-contractable care, we have, of course, the famous article by Kenneth Arrow in 1963, which kind of speeded up health economics, and who said, well, in those cases, non-profit providers are basically the element of trust in here. And of course, that's how the whole system runs, more or less non-profit. So I think it's okay, but if you look at what the typical economist will say, there is an underuse on quality information, although it does exist more or less.
Yeah, and in that sense, is the English model perhaps an area where the Netherlands can learn from the UK, or I'll give you a moment, and then we come back to that.
Sorry,
no, please take it now if you want. It's absolutely fine.
I think the Netherlands and the UK are very similar in many ways on the ground, actually, not so much in the regulation, but on the ground they're very similar in a lot of characteristics on healthcare. And yes, I do think that looking at transparency and indicators, and especially the use of them and the provision of them, yes, we could learn from the UK. As one more point, I think we kind of missed, and that is that the quality indicators or quality of care is not part of the choice of consumers for the health policy. So I think, what would very much help is that if people chose for a different insurer by the end of the year, that it's also transparent what is the quality of care in the networks that insurer companies do offer. And that's so hidden that it's basically not, choice information for insurance consumers.
Yeah, and I think this is a crucial point, Patrick, about also the different ways that we think about quality of care, public reporting, whose quality, and when it is important to know about this. So thank you very much for bringing this up. Carlo, we come to you as promised on this issue of quality. You already touched upon this a little bit, but please expand based also on what Patrick said.
Maybe from a Swiss point of view, because this is very contextual. First, please let us try also in Switzerland to have a good available information. Then maybe we can choose not to use it, but for the moment we just don't know, we don't have it. So quality reporting is one perspective. The second is Switzerland was, in all the evidence, in all the surveys, was one of the least developed countries. It's quite amazing for ICT use in healthcare. So quality can be, of course, I know that it's very complex, but however, ICT could help. This is the second pathway. And the third perspective is traditionally we had no gatekeeping. Also, gatekeeping can be effective or not, but a little bit more of gatekeeping, that is to solve this asymmetry of information, in giving an advice in a more structured way to the consumer can be one. I think it is one important perspective. So to promote this gatekeeping, it's something that is already coming up naturally because of people seeking cheaper premiums. But this is something that can be still exploited a bit.
Thank you. Thank you very much. We go to Luigi. Before this, looping back into this issue of cheaper premiums for the last little round, I think, Erica, if there's something crucial in the chat, please jump in. Okay, then we're fine. Luigi, we come to you. You brought in the issue of quality quite a bit. You also brought in at the very end this notion that moving towards integration, it's unclear how exactly the quality framework will continue. You also heard our other two speakers. Do you want to reflect for a second?
So on quality, so the first thing I want to say is that, well, first of all, we have to trust the profession because they are doing all the work. So in that sense, I think we have to remind ourselves about that trust that we have put into the health workforce. Now, if you think about quality indicators, to me, the most exciting development in the last 20 years is that we are able to measure some quality. No, we are able to collect quality indicators, which we just didn't have 20 or 30 years ago. And we know that there are like new ones all the time. We have like patient-reported outcomes. You have the press about the patient experience. So to me, in relation to quality, that seems to be the big next step as a regulator. The collection of these indicators seems vital and quite natural, and you could use it across different health systems. Then how exactly you use the indicators, then we can debate, and maybe that depends on each health system. So we can use it for public reporting, we can use it for pay for performance, or we can use it for monitoring or auditing. We know that hospitals are audited every now and then. So there are many different ways to use this indicator, but that's where, to me, it seems the right thing to put the effort in is, first of all, well, which one are the most exciting new indicator on quality that we should try to collect and develop and then use as much as possible.
Thank you very much, Luigi. Let me pick up on one thing that you mentioned, which is the lots of new quality indicators, and link it to one of the issues that Patrick was talking about, albeit from a different perspective, which is that high administrative burden for professionals. Because the other thing with quality indicators is that if we make our professionals collect endless different indicators in everyday practice, they don't actually have time for patient care. So we need to actually balance those things a bit. And so I link that to this other question that we had in the chat and to the insights that Patrick brought us about this idea of access, of how do we explain maybe cost containment? Is it really the competition? Did we see, for example, this underspent because some patients did not necessarily receive all the care that they needed? How do we reflect on what you see on the positive effects in the Netherlands, Patrick, with what it means for patient access on the ground? And then I come back to Carlo and Luigi for brief reflections, and then we come back to you, Patrick, to close us for today. But first, on this issue of access.
Yes, thank you, Dimitra. A couple of points. One of the questions was about the solvency, and if the solvency was about rationing. If we look, what is behind the slow growth in cost, it's more volume than price. Okay. So yes, we see less volume across the board, or a slow growth in volume, and of course that might we don't really know. We don't have very strong indicators, but that might lead to underutilization here and there. We also know that, I mean, this is standard economics. We also know that a stiff raise in out-of-pocket payments, for example, the deductible in the Netherlands, which was raised drastically to 385 euros in 2013, has led to some less utilization. And we do know that low-income people are more sensitive to that than high-income people. So from that perspective, there is some risk, but it hasn't led to, we cannot, for example, social economic differences are stable, high, but not dramatically increasing or anything like that. So it's very, very hard to answer. If you look at those who gain from choice and access, it's more clear. So these are people who have literacy, who are educated, who are young, who are good risk. They can choose the cheaper premiums on the market, and thus they get, more of those advantage than probably the other ones. So old chronic ill people who stay in more expensive policies. But if you look overall in access, and I think it's a nice to finish, is the fact that we have healthcare inflation now is way on the general inflation in all European countries, but also in the Netherlands. So average premium increases this year would be something like 3.5%, which is very, very, very much underneath the general economy. So I think, access is still basically very good, but it's a slow process, and markets is also about segmentation, etc. So we'll have more diversity.
Yeah. No, thank you. And I think this is something also to discuss in the next webinar, because we're already running out of time. This issue of access in general, and equity and inequity within, as you pointed out as well. Carlo, briefly to you, very briefly, on a reflection from the Swiss perspective.
Access in Switzerland is very easy from the point of view of a lot of providers, no waiting times, and providers spread all over the country because of the cantons. The challenge also for political consensus, the big challenge is 22% of out-of-pocket, 1/3 of adults that did choose to have the maximum deductible, that is 2,500 francs, that is almost 2,500 euros. This is hidden waiting times, because if you arrive to October, you will jump into the next year in order to get the consultation. So this is politically the biggest challenge for the system. I just give the very last news of last week. Patrick was thinking about a 3% of increase in premiums in Switzerland. Insurers have announced 10% of increase next year.
Okay. So I think that's already quite a signal, and I'm sure we'll be back discussing this in maybe a year's time of how that has worked out. Luigi, you briefly mentioned in your spotlight this issue about the private providers treating the lowest case mixes. There again, I think we introduced the issue of inequity a little bit. I don't want to preempt you and make you talk about that. I'm sure you have something already in mind based on what the the previous two speakers said. So over to you for your reflection on access before going back to Patrick for an outlook.
Yeah, I had 2 points about quality. One is about quality reporting, as I said, the data collection, and the second one about integrated care. So you said that collecting quality data can be quite costly, but that doesn't have to be the case. So if you think about administrative data, you are calculating risk-adjusted mortality and readmission rates. That's not very costly for the provider. Some others, like patient-reported outcomes, is a little bit more costly, but we can take that burden out of the doctors. It doesn't have, if you are just collecting the data, it doesn't have to be the doctors who do that. So that's my point about quality. About the integrated care, that's basically one dimension of quality as well. If you can improve if you can provide the integrated, coordinated care, that's an improvement in quality. So in relation to competition, we can think how can competition support integrated care? The main dimension that I have in mind is like patient choice. How can we integrate patient choice policies with integrated care? Because integrated care is so patient-centered, patient choice really should be part of it. Now, this is like a dimension of competition. We cannot call it competition if this makes it more politically sustainable, but we can still think about how does competition help to support integrated care. Thank you.
Okay, thank you very much, Luigi. I think a lot of very useful and fascinating insights on quality, on access, on equity. Patrick, you heard all of that. You heard the questions and sometimes concerns of our participants. Over to you for a last reflection before we switch off for today.
Very, very brief. So thank you all for being here, for joining this this webinar. So I'll just have 3 points. Did it work for the last 10 years? Largely yes, especially on the fiscal side, the reforms. Is it without the problems? Is the no? It does has its problems. Especially slow differentiation in access, not enough focus on quality probably. And third, will it be sustainable? Yes, with another big reform somewhere in the next 10 years, probably it will. I mean, the flexibility is I think one of the better things for policymakers that can make it sustainable. You can adjust rather easily to such a model. So thank you, and hopefully see you another time.
Thank you very much, Patrick. If you do another reform in 10 years, then in 25 years, we will all be back here and discussing how it went. Thank you all very much for joining us today. I hope you found this as interesting as we did. This was really, really, really insightful. Thank you to our participants. Thank you to our speakers, and see you soon again, hopefully at one of our observatory webinars. Have a nice afternoon, everyone. Bye-bye.